Hello, this is Janet Michael. In addition to hosting The Valley Today each weekday at noon on the River 95.3, I also produce podcasts, and I'm excited to introduce you to a new podcast series in partnership with Lord Fairfax Community College. Having provided higher education and career training for the past half-century, LFCC is tightly interwoven into the fabric of the Northern Shenandoah Valley and Piedmont regions. Join me every week for conversations with current and former students to hear their funny and inspiring stories as we learn about their journey to higher education, the role that LFCC has played, where they are now, and where they plan to go. We'll also talk to current and former professors about their experiences and best memories of LFCC over the past 50 years. Get every single episode as they're released on our website at theriver953.com under the podcast tab, or you can subscribe for free in Apple Podcast, Google Podcast, on Spotify, Amazon Music, wherever you listen to podcasts. Just search for LFCC Stories. Hello, and welcome to The Valley Today. I am your host, Janet Michael. October is National Physical Therapy Month, so we thought that would be a great topic for our community health partnership that we do every single month in partnership with Valley Health. So on the Zoom screen with me today is Joanna Jenkins. She is the Rehab Office Specialist. Along with her is Shelly Anna-Laura. Shelly, did I get that right?
That's right.
All right. And I understand that I'm not even going to try because thankfully in my notes it says she goes by BB. So BB Stewart is also joining us on the Zoom screen, and she is an occupational therapist. So thank you, ladies, for coming to hang out with me a little bit today.
Thank you for having us.
Joanna, I'm going to start with you. Give me an overview of physical therapy. Tell me a little bit about what Valley Health offers by way of physical therapy.
Sure. So here at Strasburg, we focus, of course, on our community, this small town here. We offer PT and OT services such as dry needling. They do women's health, pelvic floor dysfunction, the LSVT big program for Parkinson's. We do vestibular rehab, neurostroke patients. They co-treat and coincide comprehensive exams with PT and OT and work together on that. And then we schedule the patients accordingly, of course, for that. Experience is not the word, but we have over 36 years of people here at Valley Health with the people that are here, the therapists that are here. They've been here for 36 years total. So
it's kind of a big deal because, people do tend to move around a lot. So to have a group of people that combined have been there for that length of time really does, I would imagine, make patients feel better because the same person is there if they have to go back multiple times.
Yes.
So, Shelly, I'm going to start with you because I think everybody thinks that physical therapy is what you get after you break a leg. And it's they drill it down to something very, very simple. And Joanna just rattled off a list of things that are physical therapy that I don't think a lot of people understand are included under that umbrella. She mentioned dry needling, and I know a little bit about it because I have a friend who's had it done. Tell me about dry needling.
Sure. A lot of people don't even know that that's a service that we offer here, but actually myself and Dave Sims, we both can dry needle, and it's extra certification through a couple different places that you can go, and you have to test out to get the certification. But if people are having pain for like chronic time period and other things have not helped that they have tried, a lot of times dry needling can help decrease their pain and oftentimes get rid of the pain because we're abolishing the trigger point or a tight tissue or a dysfunction in the tissue. So a lot of people think similar to acupuncture, but actually one of the only similarities is the needle. The needle is very thin. It's a monofilament. Nothing goes in and out of it. And it actually is intramuscular, and that's the main difference. So I don't know a ton about acupuncture, but I know it's based on like channel, meridian, and chi, but dry needling is not. It's based on, inserting the needle. It goes intramuscularly, and we're trying to elicit a local twitch response or cramping to help decrease that trigger point or that tension or tone in the tissue to help alleviate some of the pain.
So Mary was on the show with me about a year ago, and at the time I was suffering from a frozen shoulder, and she was saying that dry needling would be a good option for potentially getting my shoulder to move and to eliminate some of that pain. So I'm guessing those are some of the things that you can use that for.
Yeah, so it definitely decreased some of the pain, but it also increases mobility and function too. So like if you came to us during that time, not only would it help with the pain, but you would notice that you'd be able to maybe reach into the cabinet or reach behind your back, which were probably before dry needling, painful or limited movements that you couldn't do. So it's quality of life and improving the mobility function, but also decreasing the pain to help the patients.
Joanna also mentioned that there was something called LSVT Big, which helps with Parkinson's disease. Tell me about that.
Yeah, so that's a program that the National Institute of Health has spent billions of dollars researching, and we offer it here at this location and also in Mount Jackson with one of our other therapists. But it is a 4 times per week for 4 weeks, so 16 sessions with a therapist one-on-one. Each session is an hour in length, and there is a protocol or a certain exercise progression of 7 exercises that they'll do, a sit to stand, walking big, and then we kind of get to know the patient and find what are you having trouble with? Trouble putting your coat on, maybe opening the door, or stepping over a transition, changing a walking surface, different things like that. So as we get to know the patient through our history upon the initial evaluation, we take that, and from there we develop 4 to 5 things that they're having difficulty with that we do each time, and then we also work on a daily task. But it's an excellent program. We've seen great success and really great compliments, throughout the community with what we do. And it's hard because I see them 4 times a week for 4 weeks. So I see them every day pretty much, but it's nice to have other clinicians comment and say, hey, I noticed this patient was able to do this today. So it's really nice to have, extra set of eyes to help us too here, and because it's such a great clinic for that, to help with the patients. But a lot of these patients, their quality of life, and they're not able to do as much as they used to do. They're frustrated. Sometimes they're depressed or they've given up. So this is a program no matter where you are, whether you're ambulatory and able to exercise, whether you're in a wheelchair and all we can do is work on exercises on a table. There's different progressions depending on where you are throughout your treatment of Parkinson's.
It's amazing. It's really awesome.
Absolutely
To do that.
Well, and I would guess it's one of those things that, do people normally know that it's even available? Because we get stuck in these lanes where we think, well, this is how this particular disease or disorder is treated. And you don't think to look outside the box with something like this.
No, I don't think it's advocated enough for the patients. I don't think a lot of people know it even exists.
And there's another component with that, with the speech therapy, with the LSVT that is offered in Woodstock too. And that's probably something that people don't know that much about.
BB, let me ask you, because you're an occupational therapist, so that you're dealing with people who have work issues, maybe sitting at a desk all day. Is it that somebody's gotten hurt on the job? What does an occupational therapist help somebody with?
That's a really good question. And if I had $1 for every time somebody has asked me that, I could have retired about 20 years ago. But it's a very good question because it's not something that you typically hear of or would normally think of as far as rehab is concerned, particularly with an orthopedic problem. We're similar to physical therapy in some ways with outpatient in that I basically will work with people primarily on orthopedic injuries. In outpatient, frequently I'll work with people that have had an elbow injury, a broken wrist, a tendon injury. But occupational therapy itself, that basically is looking at anything that occupies a patient's time. So as you mentioned, if it's a work-related injury, I say lots of those, but it can also be anything else. Even if somebody is having difficulty performing their self-care tasks, that is a big focus of an occupational therapist. We want to try to get back to being as independent as possible in every aspect. So if it is getting back to work, if it is even being able to get dressed independently, particularly for our neurological patients, if it is trying to get back to being able to write after a hand injury. It's very all-encompassing.
How is it different from physical therapy?
Well, that's a good question also. I would give you an example that I've used quite a bit. If someone is coming to us to see us after a stroke, and they have an order for physical therapy and occupational therapy, say Shelley and I are going to co-treat or co-evaluate a patient. There are many things that we need to both know about the patient. What their function was before, what they enjoy doing, what their goals are, what they're having difficulty with, what's important to them. Then the physical therapist would look at how are they able to walk? Are they able to get up and down, in and out of bed, getting in and out of a vehicle? Do they need any adaptive equipment to help them ambulate? How are we going to strengthen them to be able to be independent with that? Occupational therapist comes at it a little bit differently, assessing upper extremity function. So did they lose their ability to use an arm, for example? Are they able to get themselves dressed? Are they having problems with their processing, either visually or cognitively? And trying to help them to be as independent as they can be, and also working with adaptive equipment. Do you need something to help you be able to get your pants on again? We work with that kind of thing. So physical therapists are trying to help them to be as independent as possible with their functional mobility, their ambulation, using a walker or a cane or anything like that. And then I'm trying to help them to be independent with their bathing, their dressing, their upper extremity use, their fine motor coordination, their visual processing, their cognition. So together we work on trying to help all aspects.
Well, and you really do have to come at it from a different perspective because, as I mentioned earlier, there were things that I started doing differently when I couldn't use my arm that I didn't even realize I had readapted and was doing differently, and I was doing them wrong. So until you're asking me, how do you do this? And you know how I'm supposed to do it, I may not even realize that I'm making it worse by just adapting in my own way.
Exactly.
Interesting. Well, let's take a quick break. When we come back, can we talk a little bit more and maybe talk about some things that we're all probably doing now at home that we shouldn't be doing that maybe could keep us out of OT or physical therapy?
It sounds good.
All right, we're going to do all of that in just a couple of minutes. We are on the Zoom screen today with Joanna Jenkins, Shelley Anna Laura, and BB Stewart. This is part of our community health partnership with Valley Health, and we're going to come back and talk with all of them in just a few minutes for National Physical Therapy Month. I am Janet Michael, and you are listening to The Valley Today.
Do you know anyone who is struggling with financial hardships because of coronavirus? Our new webinar called Coping with the Money Crunch can help. We'll talk about immediate options to consider, revising or creating a spending plan, and lots of community resources. Then we'll cover how to narrow your priorities, contact creditors, and avoid scams and risky loans. The webinar is free, and you can either join by phone or through Zoom on a smartphone, tablet, or computer. You can find out more by visiting the Northern Shenandoah Valley Financial Education Program on Facebook or calling Karen Poff at 540-635-4549. Let me show you how to make your own plan or help someone you care about get through the crisis. Call 635-4549 or visit at NSV Financial Education on Facebook today.
Welcome back to The Valley Today. I am your host, Janet Michael. Happy Thursday as you are listening to the show today. We, however, have pre-recorded our conversation on a Tuesday afternoon. We are chatting with our friends over at Valley Health. This is part of our community health partnership, and October is National Physical Therapy Month. So we are on the Zoom screen today with Joanna Jenkins, Shelley Anna Laura, and BB Stewart, talking about some of the misnomers to a certain degree of physical therapy and occupational therapy. And we were talking in the first segment, Shelley, Joanna was giving us a rundown of some physical therapy options for people. And one of the things that she mentioned was pelvic floor exercises. I mean, explain to me what that is.
Actually, a lot of people don't even know we treat this, didn't even know they could come to therapy for this. But if you are having difficulty with incontinence or leakage, or have like a prolapse of like the bladder, if you have pelvic pain, constipation, and then some maybe pain throughout the region, either while you're pregnant or after being pregnant, one of the options that we can work on with the patient, because it can also be male and or female that have these symptoms, which I think is people don't know about. They just think women's health, but it really needs to be pelvic health, and it's actually important at any age. So even though we predominantly see older individuals for this, it is just as equally as important if there's a younger individual that's having pelvic pain or symptoms of incontinence or constipation, and then also too, especially after giving birth, whether it's C-section or vaginal, because we want to make sure those muscles can come back and get a little bit stronger. So it's a great option for people. The word is just not out there, and people I don't think are aware of this. But I guess what we can work on doing is working on strengthening the muscles around the pelvic floor, and also like the hip rotators and the core, kind of thinking about what's in that general area. And then that can help with postural stability, supporting the abdomen and the pelvis. It can help with bowel and bladder control. It can also help with sexual or reproductive function. And then for pregnancy, we can help support the growing fetus during pregnancy, as well as aid in childbirth. So we actually just started a peer group with Valley Health through Winchester, Front Royal, and in Strasburg to really promote this and be advocates for the community to help kind of get the word out, since not a lot of people know about this.
Well, and it's interesting because it seems to be the underlying theme here is that there are healthcare options out there to make your life better that so many people don't even know exist. Exactly. And they just feel like, oh, this is just something that happens when you get old or after you have babies, and you have to learn to live with it. And that's not at all the case.
Correct. There's so much out there that we can do for this and help with. We could certainly go into a lot of detail with this, but it's just if the patient is, experiencing this, if they can talk to their healthcare practitioner about it and get an order or a referral to come to us. I mean, we certainly want to help the community out in again, helping the quality of life and the function, because they want to be able to do their normal daily tasks or recreational activities without having to worry about, do I have an extra change of clothes? Do I have a pad? Am I having pain with this? Or can I not do this because of something? And in a way, it, changes kind of how they feel about life, or maybe how they feel about their partner and stuff like that. So anything we can do to help them, we certainly want to get the word out there and know that it is an option and you don't have to live with it.
So the process should start with a primary care physician and reaching out to them and saying, look, I heard this on the radio and this is me. And then they will make that referral to you guys for them to get an appointment.
Yeah, so you can do, primary care physician, OBGYN. If you see a women's specialist, there's a couple of those in Winchester and Harrisonburg, urologist even, sometimes GI if they're having constipation issues. So it can look like it's an array of, physicians or doctors that they could get the referral from, but any one of those can get a referral and we can get them started.
BB, during the break, you were telling me about a community mobility program. So explain that a little bit more.
Absolutely. A couple of years ago, one of the other therapists that I work with, whose name is Nancy Toole, who is a certified occupational therapy assistant, she really wanted to do more for helping people being able to drive safely. So if for instance, if someone is concerned about a loved one being able to drive safely, or even a patient themselves, she went through and this specific program and then taught me how to do it. And we're able to run a battery of tests that are off the road. We don't take anybody on the road. We're not driving rehab specialists, whom we do have in Winchester. And they are amazing. So the physician can request a referral to occupational therapy to assess a patient for returning to safe community mobility. Then I can do, in combination with the CODA, a battery of tests that is very extensive that looks at vision, cognition, function, functional mobility, range of motion, processing skills, There's a whole host of tests that we can do that give us a very good idea on whether or not someone would be safe to return to driving. If at the end of that time we have some questions, if we say, well, they did fairly well on X, Y, and Z, but not very well in a specific area, we can say, all right, can therapy help with that particular area? For instance, if they're having difficulty with turning their neck, that can affect safe driving, but is that something that Shelley might be able to help address? If they're having problems with their memory, is that something that OT or speech therapy can help address? And then if we feel that we want them to go ahead and have an on-the-road assessment, then we can make that recommendation and they can go to Winchester, where there are driving rehab specialists. Debbie Bender is one of them who's been there a long time, who can then take the patient on the road and to actually see how they're able to do that and if there are any recommendations that she can make to help them with that safely. But if they don't do well on the initial tests that I give, I am able to say with very good confidence that I can relay that information to the physician to say, I don't feel this patient would be safe, or I think they would be, but only driving on back roads or not on the interstate, only during daylight hours, and to make some suggestions because we really want the patients to be or people in the community to be safe, as driving is the most dangerous thing that any of us are going to do, unless you're in the military. It's really dangerous, not only to yourself, but to other people. We want people to be safe. And we want people to maintain their independence as long as possible. And driving is one of those areas that it's very touchy for people because they don't want to be told that they can't drive. And so they may be driving when they should not be driving. And we can make recommendations to try to help them still maintain that independence if they're safe during daylight hours. If we do not feel that they are safe, we are also have lots of community resource information on how they can get their groceries or their hair done or still have contact and being able to get what they need, but without driving. We are also there to take the heat off of the physician and the family, because usually the family are the ones that are caught in kind of a double-edged sword where they really don't feel like mom is safe to be driving, but it's difficult to tell your mother that she can't do that. So I don't have any problem telling her that. And it also puts the physician in a difficult position because they may have had, they have a long-standing relationship with this individual, and it's hard for them to say, we don't want you to do this. We are able to provide definitive, objective information. So then the family and the physician can work together on what's safest. I do not have the power to take anybody's license away. So that also it's pretty good. You're safe as far as that goes. We're just trying to get safe, objective information to then be able to provide that to the individual, the family, and the physician so that everybody can make an informed decision.
And I could see where that would work both ways, because you could have somebody who really shouldn't be driving that, again, you've got to be that person to say, no, this isn't really something you should be doing. But at the same time, you could have somebody who is more than likely capable, but maybe they're just afraid. And you don't want them to put themselves in that bubble if they don't have to. So
Right.
I think it's a fantastic option to have.
Absolutely. Absolutely. We're very proud of that. And we've had a very good response to it, but I feel that the more we get the word out, that, we could do even more.
So where would people get information about this? Is this another situation where they'd have to get a referral from a primary care physician or another doctor, or how would they start that ball rolling?
They can absolutely get a referral from their primary care physician or nurse practitioner or physician's assistant. And it is, we have to be very careful. We like to make sure that the physician understands that it needs to be written for returning to community mobility, not driving evaluation or driving rehab, because that's not what we're doing. It is covered by insurance, so that is a good thing. If they do end up having to do an on-the-road assessment or going up into Winchester, that is an out-of-pocket expense, which is definitely worth it to make sure that somebody is not going to get into a potentially life-threatening situation for themselves or for somebody else. So that's usually one of the questions that people ask, is this covered by insurance? And this initial step for the off-the-road assessment is.
Well, I would love to have my husband evaluated because he drives like he's 112 years old. So can we talk about how that might happen? Because I hate riding in the car with him. It takes us hours to get anywhere.
Send him over to BB. Send him on over.
Yeah.
So before we wrap up, we were talking also during the break. I mentioned before we went to break about the number of people that are working from home now. And I think a lot of us have gotten into makeshift workstations where we're using our kitchen counters or our tables, our sofas. I call the bed now as my nest because I can sit and spread everything out and I have the TV back there. We probably are not doing the smartest when it comes to posture, when it comes to all of these other things. Can you give a couple of tips for somebody who might be listening to just make sure they're paying more attention to that kind of thing?
Sure. This is an area that I also have worked with a lot over the years, particularly with some of my coworkers within the hospital. I will sometimes be asked to do an ergonomic assessment of their workstations. And that's usually a lot of fun because it typically does not cost anything. It's just making some suggestions. So some things to really keep in mind at home. One is to not sit for longer than a half an hour at a time. That you need to get up, even if it's for 30 seconds. You need to stand up, walk around the chair, stretch, and then you can sit back down. But that's really important. And I think that when people are doing a lot of computer work, time can get away from them quickly. But it's very important to do that just for blood flow and stretching your muscles and making sure that you're moving. The other piece is that the computers, we tend to adapt ourselves to where we put the computer. So as you mentioned, if it's on the bed or if it's on a counter, the height of the computer really makes a big difference as far as your neck is concerned. Your eyes should just be able to see the top or be even with the top of the computer. You shouldn't be down low.
As I sit up straighter.
Like this. So that there's minimal head motion, so that the computer needs to be up high enough so that as you look straight forward, you can just see the very top of the computer. Another thing is that our posture tends to be really poor when we're typing, and that goes for, I think, every single person. And that's something to keep in mind, is trying not to lean too far forward. Every once in a while, sitting up straight, pulling your shoulder blades together, rolling those shoulders, moving your head around, because this can cause increased headaches, neck pain, back pain, and you're not really realizing that it's your posture can contribute to it. The other quick thing that you can do at home is the computer screen should be no more or no less than an arm's length away from you. So if you're sitting up straight, you should be able to reach your arm out in front and just barely touch the computer screen. So that can make, I see the look on your face.
Yeah, I'm running through. I'm thinking I maybe am doing one of those things that you just rattled off. Well, and my problem is I need to get new glasses. So what I find that I'm doing is, because I have the progressive bifocals, but they don't work anymore. So I am hunched over, looking down over my glasses at my computer screen as I'm typing. It's not just old age. I'm doing this to myself.
Well, and I think you're not alone. I think you're in very good company, but it is something that can be prevented if people are more aware of, because this can actually lead them to the point where they need to have therapy for a shoulder problem or a neck problem, or you're having headaches, or you're having to take more medication because you're uncomfortable or your back hurts. But, being aware that your positioning can have a great deal to do with that is extremely important.
Well, ladies, thank you all for coming to hang out with me today. As always, I have learned something very valuable, several very valuable things in my Valley Health show today. So I do appreciate it.
Yes, thank you. We look forward to seeing your husband soon, okay?
Yeah, he is totally coming in for that. And he's going to come home on Thursday because, I mentioned earlier we're recording this on a Tuesday. He's going to come home on Thursday night and say, will you quit talking about me on the radio? But it'll be all right. I'll still get him in. We are going to wrap up our conversation today. We have been chatting with Joanna Jenkins, Shelly Anna Laura, and BB Stewart from Valley Health. It is National Physical Therapy Month, the month of October, and this is part of our community health partnership with Valley Health. I will be back tomorrow. We are having a conversation with Dylan Chapin. She is a Frederick County 4-H agent. We're going to talk a little bit about 4-H. So meet me back here tomorrow, just a few minutes after noon, and I will have that show ready to go for you.